Next topic is assessing the pelvic organ prolapse. It's a nice guideline published on 2nd April 2019. So when we are dealing with pelvic organ prolapse, we need to assess the pelvic organ prolapse. So clinical assessment in primary care, what exactly we do in primary care. And again, this part is very important, especially you have an information gathering domain for part 3. Okay, so in part 3, this history taking is going to be very important. When you are asking the history in a case of prolapse, what exactly we need to ask? We need to take a detailed history about prolapse symptoms, urinary symptoms, bowel symptoms, and sexual function. So all 4 components we need to cover. So do not restrict yourself only for the prolapse. So prolapse, urinary, bowel, and sexual. So all these 4 histories are going to be very, very important. Perform pelvic examination to rule out pelvic mass or other pathology, document presence of prolapse, discuss treatment preferences, and refer if needed. Incidental prolapse in the secondary care. Now you have found the prolapse, but it is a incidental finding. In that you can consider the referral to the clinician with prolapse expertise. Okay. Now, if the patient is with the specialist, then what kind of assessment is required? So you will assess the POPQ measurement for anterior, central, and posterior compartment. This POPQ will have a separate discussion subsequently later on. Okay, so we will do the POPQ measurement for anterior, central, and posterior compartment. Pelvic floor muscle activity we will assess, evaluate for vaginal atrophy, and exclude any pelvic mass or other pathology. Then symptom questionnaire. Consider validated pelvic floor symptom questionnaires. Imaging for prolapse, do not routinely perform imaging if prolapse is confirmed on examination. Exam not matching with the symptoms. If your examination findings are not matching with the symptoms, then you can repeat the examination in a standing or squatting position, or you can repeat the examination at another time. Okay. Then symptoms requiring further investigation. Bothersome urinary symptoms where surgery is possible, obstructed defecation or fecal incontinence, pain, symptoms which are not explained by the examination, these patients require further investigation. Assessing pelvic organ prolapse, this is the summary of same what we have discussed. 4 kinds of history that is related to prolapse, urinary, bowel, and sexual symptoms we are going to take. Examination will be POPQ, pelvic floor muscle activity, vaginal atrophy, we will look into it, and we will exclude the masses. Adjuncts will be the symptom questionnaire, and always avoid any imaging in cases of clear-cut case of prolapse does not require imaging. Okay. Repeat examination if the findings are not matching with the symptoms. Okay. Now coming to the non-surgical management of pelvic organ prolapse. So in the counseling, what we are going to discuss? No treatment versus non-surgical versus surgical option. So we have these options which are available. Either don't treat. If the patient is asymptomatic, it is an incidental prolapse, you can just discuss with the patient the findings, and the no treatment option may be preferred. And remember, it is always a shared decision making. We cannot give the option. The patient will choose the option. Okay. Second is a non-surgical option. It may be in form of vaginal pessary also. Okay. Or it may be in form of pelvic floor muscle training. Okay. Or it can be surgical option. Then what is the site of prolapse, patient preferences, lifestyle factors, comorbidities, cognitive and physical impairment, we need to look into it, age, fertility desires, previous pelvic surgery, risk and benefits of surgical or other management that we need to discuss. Okay. Now coming to the first is a lifestyle modification. If the weight is more than 30 kg, BMI is more than 30 kg per meter square, advise weight reduction, avoid heavy lifting of the weight, and prevent and treat the constipation if it is associated. For topical estrogen, now the local estrogen, the use of local estrogen, how they are going to help? They will help especially in cases of vaginal atrophy, but they will not have effect on the grade or the stage of the prolapse. Okay, so stage of the prolapse will not be changing, but the symptomatic improvement will be there. So topical estrogen, consider vaginal estrogen for prolapse with atrophy, and consider estrogen releasing ring if difficulty in using creams or pessaries. Okay, so if all options are there, creams, pessaries, and all, so you can choose the estrogen releasing ring, especially if there is a difficulty in using the creams and pessaries. Okay. Then pelvic floor muscle training. Here you will find the difference when you use PFMT, that is supervised pelvic floor muscle training. For POP, it is 16 weeks. At least 16 weeks you have to give, and this is for stage 1 and stage 2. Okay, and continue PFMT if beneficial. For SUI, what was the duration and what we have mentioned about the pelvic floor muscle training, doctor? Can minute
I didn't get.
pelvic floor muscle training
It is
in
done for 3 months, sir.
three
More than equal
months
to more than
eh,
equal to 3 months. It is more than equal to 8 contractions, 3 times a
3
day.
times a day for 3 months. Okay,
Three
that
months.
is for
Yes.
SUI, and here
Yes,
it
sir.
is for 16 weeks. So do not get confused in
Con
the duration. And
Okay, sir.
this, for stage 1 and stage 2, this PFMT are used as a conservative treatment. Okay. Then coming to the role of pessaries. Symptomatic pelvic organ prolapse, either alone or along with the PFMT, you can use it. Then before starting the pessary, we need to discuss. Let's see the look for vaginal atrophy and treat. Okay, because otherwise it may lead to complication. So if there is a vaginal atrophy, you will first treat the vaginal atrophy. Explain trial of multiple fittings are required. Okay, so it's not a one time you fit the pessary is done, because patient to patient the size will be different. So multiple fittings will be required. Discuss sexual activity concerns, discuss complications, discharge, bleeding, difficult removal, expulsion, etc. Explain pessary should be removed every 6 monthly. Okay, and there is a special pessary clinic. So the patient should come for follow-up every 6 months. For those at risk of complications, the patient is advised to come in the pessary clinic and refer to urogynecologic service if local pessary care is not available. Okay. Suppose now what are the different non-surgical options that we have seen, and we will compare these non-surgical options. One is a lifestyle that is required for all cases of pelvic organ prolapse. It is safe and core to management. Limited effect for advanced pelvic organ prolapse. Then topical estrogen, especially if there is atrophy, you will go for topical estrogen. It improves the vaginal tissue, and there is no effect on the prolapse degree as such or the stage of the prolapse. PFMT for stage 1 and 2, it improves the symptoms, it is safe, but it requires supervision and compliance. So this supervision is going to be very, very important. These are the supervised pelvic floor muscle training. Okay. Then pessary, symptomatic POP is the indication for pessary. It is effective symptom relief and need regular follow-up, and complications are possible with the pessary. Okay. Now coming to the surgical management of pelvic organ prolapse. So when to offer the surgery? Offer to women whose symptoms persist or who decline non-surgical options. Okay. So the patient should be symptomatic, or the non-surgical options have failed, or the patient have declined the non-surgical options. Okay. You will always use PDA, that is patient decision making aid. For mesh, always discuss the mesh concerns, and that you need to highlight that the long-term data about the use of mesh is limited. Fully document the mesh details, ensure procedure recorded in the national registry, and provide device information to the patient. Surgery for uterine prolapse. Now, when we discuss about various surgeries, what are the points which we need to take into account? Okay. First, one is a non-surgical options. Second, hysterectomy versus uterus preserving procedures. Third, complications and lack of long-term data. And we will always use the NICE patient decision aids. Okay. So now we will discuss about the surgical management. Okay. Now, when we are discussing the surgical management, what is the wish of the patient, or willingness of the patient, whether it is a uterine conservation is important or not important. So if there is no preference on the uterine preservation, okay, in that particular case, you can go ahead with the vaginal hysterectomy plus minus sacrospinous fixation. Okay. Or other options such as vaginal sacrospinous hysterospexy, Manchester repair, and sacrohysterospexy with mesh, either abdominal or laparoscopy. So if the patient does not want the uterine preservation, then we have all these options. So it is not a preferred that uterus may or may not be preserved. Then vaginal hysterectomy plus minus sacrospinous fixation, vaginal sacrospinous hysterospexy, Manchester repair, and sacrohysterospexy with mesh. either abdominal or laparoscopy. If the patient wants to preserve the uterus, if this is must, then hysterectomy is not an option, but rest of the options are available. That is vaginal sacrospinous hysteropexy, Manchester repair. However, if the future fertility is not desired, then only go for Manchester repair and sacrohysteropexy with the mesh. So these options are available. Now, when we are discussing about the mesh insertion, always record outcomes in the national registry and MDT review if future pregnancy is desired. Okay. Now, surgery for the walled prolapse. What we have seen up till now? Surgery for the uterine prolapse. Now, surgery for the walled prolapse. Discuss options plus decision aids. We will offer vaginal sacrospinous fixation, sacrocolpopexy, either abdominal or laparoscopic with mesh. And mesh procedure will always require documentation in the registry. Please remember. So there are two options, vaginal sacrospinous fixation or go for sacrocolpopexy. It may be abdominal or laparoscopy. So walled prolapse, two options are available, vaginal sacrospinous fixation or sacrocolpopexy with the mesh. It may be abdominal or it may be laparoscopy. And for both, that is the uterine prolapse, for walled prolapse, another option is a colpoclasis. Okay. Consider for women with walled uterine prolapse who do not desire penetrative vaginal sex and have high risk, high operative risk. So these patients can go ahead with the colpoclasis. If you have an anterior prolapse, the surgery will be anterior repair without mesh. If there is a posterior prolapse, then the surgery will be posterior vaginal repair without mesh. Okay. And follow-up after the surgery will be at 6 months. Vaginal examination will be done for mesh exposure and ensure access to the referral for recurrence or complications. Okay. Now, surgery for women with both SUI and POP. Up till now, what we have seen, surgical option. Surgical option for uterine prolapse we have seen. Surgical option for walled prolapse we have seen. Surgical option for anterior repair we have anterior prolapse we have seen. Surgical option for the posterior prolapse we have seen. That also, whether she wants to conserve the uterus or doesn't want to conserve the uterus. Also, along with the fertility. So these are the options which we need to take into account. And next is the surgery for women with both SUI and pelvic organ prolapse. So concurrent surgery for anterior or apical pelvic organ prolapse and SUI. Okay, that can be performed. If there is an anterior or apical pelvic organ prolapse and SUI, that can be done. However, uncertainty of long-term continence benefit for more than 1 year needs to be discussed and possible increased complications with combined versus staged surgery. Okay. So combined surgery, that also we need to discuss a possibility of the increased complications if the surgery is combined versus if the surgery is staged. That means you treat either of the first and then go for the another surgery. Then management of the mesh complication. Symptoms suggestive of mesh complication may be pain such as pelvic, vagina, back pain or leg pain, groin, provoked or unprovoked nerve along the nerve distribution. There can be vaginal discharge, bleeding, dyspareunia, partner pain. Urinary symptoms such as retention, dysuria, recurrent urinary tract infections, bowel symptoms like pain, bleeding, mucus, or incontinence, and signs of infection can be there. And these are the symptoms which are suggestive of mesh complication. If you have a mesh complication, you have to refer the patient to urogynecologist, urologist, or colorectal surgeon. Here is the role of regional MDT. Okay, mesh complication will always go to the regional MDT. Okay, specialist evaluation will include detailed about the mesh surgery history, then pelvic floor and pain questionnaires. We have to do the vaginal examination, palpation, exposed for the exposure of the mesh, extrusion of the mesh, pain mapping we have to do, rectal examination if indicated, and neurological assessment if there is any weakness that we need to do. Okay. Now here there can be question. Now your scenario may mention that the patient has presented undergone some mesh operation and you have detected some mesh complication and they will give you the examination finding. Then first thing will be you have to refer the patient to the regional mesh center. That is the initial management. Okay. Now depending upon the area of exposure, if the area of exposure is small, less than 1 centimeter square, then and the patient is asymptomatic, you go for follow the local guideline, individualize the investigation plan, okay, and confirm complication must be recorded in the national registry and reported to MARA. Okay, so when you have this mesh complication, first thing you will do is a regional mesh center referral. Okay, you will also note down the area of the how much is the area of exposure, and accordingly you will follow the local treatment guideline that we will see subsequently. And you will along with the MDT you will individualize the investigation plan. Okay, now let us see mesh complication, symptom and action. If it is a pain which may be pelvic, vaginal or nerve, specialist referral is required. If there is a vaginal discharge, bleeding, dyspareunia, you need to do the vaginal examination. If it is urinary retention or recurrent urinary tract infection, urology or urogynecology input are required. If there are bowel-related symptoms such as defecatory pain or bleeding, colorectal input is required. If there is infection such as fever, discharge, you need to evaluate and refer accordingly. Okay, now let's see what kind of investigations are required if there is a mesh complication. Okay, so various investigations are there, and what is the role of investigations? Sometimes they can ask you the specific investigation. So here the investigations are laparoscopy, MRI, okay, then ultrasound, CT, fluoroscopic studies, then urinary flow studies, along with the post-void residual urine and cystometry and neurophysiology. So these are the different investigations, and what is the role of each investigation that we will see. Now the laparoscopy as a investigation in cases of mesh complication, it is applicable for mesh types which are done abdominally or laparoscopically placed mesh for pelvic organ prolapse. Okay, if the patient presents with pain or suspected bowel entrapment, suspected adhesion secondary to mesh. So if these bowel related symptoms are there following the mesh surgery, you have to select the laparoscopy. And benefit is that direct visualization is there. It aids in the management planning also. And it has got an aesthetic risk, anesthetic risk of bowel perforation, risk of laparoscopy as such, including the bowel injury will be there. So these are the disadvantages or the risk of the laparoscopy, but it is indicated if you are suspecting bowel related complication, especially bowel entrapment or etc. Okay, so that becomes invasive investigations. But before that, you can do the MRI. But when you perform the MRI, it should be protocol and should be read by the experienced clinician. Okay, this is must. The person who is reporting the MRI should know the detailed history also and should be experienced also. It is also indicated for all types of mesh. So if you have a suspecting mesh infection or fistula mapping or mesh localization for surgery. So before surgery, you will do this MRI. Okay. Back pain after abdominal mesh, possible discitis or osteomyelitis. So excellent anatomical mapping is possible with MRI. It identifies the site of infection or the fistula. Okay, so the second investigation is MRI. Okay, another is ultrasound. It may be transperineal, transvaginal, and translabial. Because with MRI, what happens? Availability is an issue. While the most important and easily available is the ultrasound. Okay, so it is applicable. You can do vaginally placed mesh for incontinence. You can go ahead with this ultrasound. Indications will be pain, voiding dysfunction, suspected infection, suspected urethral mesh perforation, and mapping for excision surgery. Okay, there is the role of ultrasound. Benefit is that it shows implanted material, identifies midurethral sling, shows mesh in relation to the vagina and urethra. So especially if you have a mesh which is related to SUI, okay, in that particular case, this ultrasound. If you have operated for prolapse and abdominal or pelvic, either wall prolapse, or you have used mesh, then definitely MRI will be preferred. But if you have operated for SUI, then you can go ahead with the ultrasound. Okay. The risk is only discomfort during the examination. Another investigation is a CT scan. This is also indicated for all types of mesh, but not ideal for showing the mesh material. Okay. However, it is indicated for suspected urinary tract injury, bowel injury, bowel obstruction, etc. It is useful for detecting urinary fistula or bowel injury, but with CT scan, there is a radiation exposure and risk of contrast reactions. Next is a fluoroscopic studies, either cystography or contrast enema. This is also indicated in all mesh types. So suspected urinary or bowel fistula, you may have to do this fluoroscopic study, but however, again, the risk will be there of radiation exposure and it aids in the management planning. The next two indications are urinary flow studies, PVR and cystometry. Again, it is integrated in all mesh types, especially when you are avoiding dysfunction and urinary incontinence. It helps in the planning the management. However, there is a risk of urinary tract infection, radiation risk if you use the fluoroscopy. Okay. Then neurophysiology, that is nerve conduction studies. It is indicated for all mesh types when you suspect the nerve injury. It helps to diagnose the nerve entrapment and hard to perform, but may worsen the pain also. That is one of the risk. Okay. Now coming to the managing the complications associated with the mesh surgery. Okay. Now general consideration before removing the mesh. The key counseling points are discuss decision with the woman and the regional MDT, limited evidence comparing partial, complete or no mesh removal. So pre decision, this counseling is going to be very, very important. You need to tell that there is a limited evidence which compares either partial removal, complete removal, or no mesh removal at all. The mesh removal can cause major complications such as organ injury. It may worsen the pain, urinary, bowel, or sexual dysfunction. Symptom relief is not guaranteed. Complete removal may not be possible. Partial removal may be as effective as full removal, and recurrent SUI or prolapse may occur after the mesh removal. So if you remove the mesh, there can be recurrent SUI or the recurrent prolapse. And partial removal may be as effective as full removal also, and complete removal may not be possible. And even if you remove, then also symptom relief is not guaranteed. So this all we need to discuss. Okay. Now, as I said, there can be question about the vaginal mesh exposure. So when you are given a scenario about the mesh surgery, there is a history of mesh surgery and the patient presented with certain complaints, then look for the area of mesh exposure. If it is less than 1 centimeter and single area, discuss topical estrogen. Okay. So the treatment of choice will be the topical estrogen. If it is more than 1 centimeter or there is an extrusion, okay, so if there is more than 1 centimeter square or there is an extrusion, we will consider either partial or complete removal. Okay. If there is no improvement after 3 months of estrogen, then we will consider removal of the mesh. Okay. If there is exposure plus infection, provide imaging and further treatment. So you have to go for imaging if there is exposure plus infection. So mainly they can ask you about this topical estrogen. If the area is less than, remember it is, if they give you exactly 1 centimeter, then here it will be partial or complete removal. If it is less than 1 centimeter, then go for topical estrogen. Okay. Then follow-up review will be within 3 months if the managed patient is managed conservatively. Now coming to the mesh sling, specific counseling related to the mesh sling. Okay. We have to mention that if you go for complete removal, there is a higher risk of recurrent stressurinarincontinence incontinence. If you go for a partial removal, there is a more risk for further extrusion, and complete removal may not be possible. So if there is a mesh sling which is used for SUI, we need to discuss these particular things to the patient. Now, you have used the mesh for pelvic organ prolapse. For pelvic organ prolapse, you need to discuss that complete removal may not be possible, higher risk of urinary or bowel injury, and risk of recurrent prolapse will always be there. You have abdominally placed mesh. Okay. In that particular risk of urinary and bowel injury, recurrent prolapse may require abdominal surgery. Complete removal may not be possible. If the patient has got pain and dyspareunia, if suspected mesh related, discuss with the regional MDT. If no abnormality is found, consider pain management, vaginal estrogen, dilators, counseling and psychosexual therapy, physiotherapy, and if there is a persistent pain, then seek multidisciplinary team advice. Okay. Now managing urinary complications. So mesh perforating the lower urinary tract. Refer to the mesh complication center. Counseling for women considering mesh removal. Urinary symptoms may not improve and new symptoms can happen. SUI may recur, higher risk with complete removal. Complete removal may not always be possible. Further treatment may be required, and there is a risk of urinary fistula. If there is a voiding dysfunction, then discuss mesh sling division. So if the patient has got voiding dysfunction, so this can be a question. So if following SUI, there is a voiding dysfunction, you can go for mesh sling division. Okay. For persistent problems, refer to the specialist mesh complication center and explain higher risk of recurrent SUI after excision compared with division. Okay. So higher risk of recurrent SUI is there if you excise rather than divide this sling. Okay. And further surgery may be required. Okay. Now coming to the bowel symptoms, managing the bowel symptoms. Functional bowel disorders follow nice fecal incontinence guidance or local protocols. Bowel complications directly related to the mesh. So problems may include erosion, stricture, fistula, etc. Discuss in regional MDT and develop an individualized plan. Counseling points will be complete removal may not be possible. Bowel symptoms may persist or recur, and temporary or permanent stoma may be required. So if the patient has got bowel complication, these are the things which we need to keep in mind. So that finishes our topic about the pelvic organ prolapse, especially the complications with mesh. Okay, thank you.